Good day, everyone. My name is Dr. Sandeep Morkhandikar. I am a consultant nephrologist and kidney transplant physician working in Pune. I am mainly attached to Ruby Hall Clinic, Pune, and I have a clinic in Kalyani Nagar, Pune. So today's my topic of discussion here is pregnancy in a female kidney patient. Can a kidney patient who is a female can get a pregnant? As one of the most important thing, we see many female patients suddenly getting pregnant and land up in dialysis because of some unknown factors or some known factors sometimes. So as we know, means kidney people usually have a difficult reproductive life. Kidney function is directly controls the ovulation or fertility of a patient in a female patient, and definitely there are multiple endocrine possibilities involvement in that. Usually after transplantation, these kidney functions once recovers, this axis or pregnancy cycle, ovulation cycles recovers very fast, and patients are easy to get pregnant. One of the first pregnancy in a post-transplant patient is documented way back in 1958. So you can just imagine that it is a very long, successful story which is going on again. Definitely, there are a lot of endocrine dysfunction happens in the kidney. Kidney disease patient, particularly hypothalamic pituitary and gonadal axis, there is axis in the body which controls this ovulation cycle in the female. And once the kidney is transplanted, kidney is doing well and it is recovering well, it stabilized well. Over a period of usually 3 to 6 months, sometimes up to 1 year, this axis is settled back and they usually have a normal physiological response which is required to get a pregnancy. So definitely pregnancy after kidney transplant is really not as simple as a normal patient. It is a definitely high risk, required some multidisciplinary approach by a nephrologist, by a reproductive specialist, particularly infertility specialist, and a setup where the management for blood pressure changes in the pregnancy, baby growth, or infertility or preterm delivery, fetal growth restrictions, and kidney rejections are managed easily. A successful pregnancy is a regular, it's easy to do if you are managed well before the pregnancy, during the pregnancy, and after the pregnancy. So it is a part of definitely a transplant physician, a gynecologist, and a neonatologist who are expert in managing such kind of patients. So one of the most common question females usually have, okay, even if I get a transplant, can I go get a pregnant immediately? So definitely multiple guidelines are there, like National Health Services, NHS guidelines from UK, or American Thoracic or American Society of Transplantation guidelines. Usually minimum waiting time is around 1 year at present, sometimes up to 2 years depending upon the overall graft function. Few parameters are always there when we are planning a pregnancy. First, how much is the blood pressure control, how is the graft functioning, how much is the creatinine, what is the protein loss in the urine, and any past recent rejection episodes, and what all medications patients is taking. There are a few medications on which patients should not become pregnant because the babies get a lot of defect in the central plant, cleft lip, cleft palate, microtia, and these are usually very difficult to treat. The people, kids will get succumb to the over a period of time. So better to avoid these medications when you are planning a this kind of a pregnancy in transplant population. Usual recommendation is withdrawing these medications like mofetil, sirolimus, usually 6 weeks to 3 months prior to the planned pregnancy, changing it to the pregnancy safe medications, and start planning kidney pregnancy. Definitely, there are some factors that increases the chance of a pregnancy or like a poor outcome even after transplant. There are some patients who get rejections or some other parameters. Definitely, there is a chance to treat them again. So usually creatinine more than 1.4 milligram, persistent hypertension which is more than 130, 180, and proteinuria more than 500 milligram in the urine usually are not a good factors for a pregnancy outcome even after transplant, because these usually worsen during the transplant again. Younger age of transplantation usually associated with the conception rates, usually have higher conception rates and better pregnancy outcome because of the overall health of a patient. Definitely, there are always these are pregnancies are definitely have few complication with the mother, complication with the fetus or a baby, or complication in the graft. So all these things are easily manageable, controllable, detected earlier. So what are the usual complications in the mother? That there is a higher risk of cesarean sections in this population because the kidneys are placed in a particularly lower in the abdomen. There cannot be a stretch, so they cannot stretch. They may not strain that much. Always there can be a higher incidence of oral cesarean sections as well as which can almost, I'll say, almost everybody requires cesarean section unless otherwise very difficult to go with all these things. Because of the medication, overall, there is always more of a complication in this kind of patients. What are the usual complications in the fetus? Growth, lower fetal growth. The weight of a baby is usually lower than the normal, particularly in this kind of people. So the incidence is as high as sometimes 80%. Preterm deliveries before the term, like before completing 10 months of pregnancy or 40 weeks of pregnancy, usually is again higher, almost 40 to 60% as compared to the hardly 5% in the general population. Usually higher serum creatinine, more than 1.75 milligram, or hypertension, which is required more than two medications, and proteinuria more than 500 milligram, usually associated with the major fetal complications like low birth weight, IUGR, all these things. And definitely, there have been, for example, as I told you, as the incidence of miscarriage or misabortions is also way higher than the general population. It can be because of the medications, infections, or recent rejections, change of medications. All these parameters do affect. But usually, what can I say? A miscarriage rate is not related to the hypertension or proteinuria, whatever the studies were able to find. As we are discussing the complications, one just a point to highlight required change in immunosuppression during and of course immediate post-pregnancy. As we are discussing that there has to be careful stepwise change of immunosuppression after the transplant. Usually it is started at the end of a 6 months to 1 year or minimum 3 to 6 months after the last rejection, depending upon the severity of the rejection, how severe was the rejection, and how much is the level of the creatinine, all the parameters, how the kidney function is doing overall. So two medications are usually changed are like mofetil and sirolimus or everolimus. All these three medications are teratogenic. Teratogenic means they have been proven to have side effect in a growing baby, and they has to be stopped minimum 6 weeks to 12 weeks prior to the conception. And the other medication which can be continued like acrolemus, cyclosporine, azathioprine, and low dose prednisolone has to be there in the form of continuation of graft function. Usually, the requirement of a dose of this tacrolimus and cyclosporine increases in the pregnancy, which is a range from 20 to 25% with the proper monitoring of the tacrolimus level or cyclosporine level. And frequent monitoring and therapeutic effect has to be changed. As we are discussing, there is always effect on the allograft or the kidney function or the kidney on the kidney. Because the normal pregnancy, there is an increase in the volume of the body, there is increased swelling in overall, and overall effective plasma means multiple other parameters are affecting in the body, which increases, this tries to increase the kidney function of a single kidney, which is that new kidney for the patient. So this is usually manifesting increase in the GFR of the patient and decrease in the serum creatinine and urea. But in kidney transplantation, these changes can be minimized or absolute sometimes when they can change to rise in creatinine, rise in blood pressure, rise in more swelling in the body. And even this thing happen with the proper medication and medication adjustment. Once the delivery has happened, they usually reverts back to the baseline at the end of 3 months. Almost 85 to 95% of the population will come back to the baseline at the end of 3 months if everything was fine. As we discussed, these changes are usually very much problematic. Allograft function or kidney function changes are not up to the mark if the patient creatinine is more than 1.5 milligram per deciliter or protein urine protein excision more than 2500 milligram, as we discussed in the past. One of the real confusion, what should we do about the breastfeed if the baby is there? Definitely, as we are already changed few of the medication like mycophenolate, mofetil, everolimus, sirolimus, these are usually not given in a postpartum or a post-delivery patient because these have been shown to have some side effect in the babies, and there is no appropriate or enough evidence or enough data to say that these are safe in the postpartum. Even the belatacept, which is a new kind of a drug available for the post-transplant patient. So normally we continue with the same medication which the patient has prior to the pregnancy, and usually it is continued for 3 to 6 months till the baby is off breastfeed and patient is back on the normal. Baby is eating well. There is no medical major feeding related issue to the baby. In conclusion, definitely pregnancy can be achieved in kidney patients who female kidney patients. Kidney transplant is one of the very good option for them to avoid major complications. Uh, Female patients who have already impaired kidney function, like a creatinine more than 1.5, 1.6, 1.7, and who are trying to get pregnant, they are very high risk of multiple complications. Sometimes they go in dialysis also if they are not managed, and outcomes are of the baby also are not. Proper pre-pregnancy counseling by a nephrologist or their gynecologist is required for this kind of a patient. Transplant patients can get pregnant at the appropriate time, and it has been usually well explained by their nephrologist to them at the time of they are getting transplanted. As we know, that majority of the females once transplanted achieve the fertility very high. So that's all for the day, and I'm very happy if you have some questions or like that, and definitely I'll be able to answer. Thank you. Have a good day.